Welcome to the Healthcare StarcAst, the podcast that goes beyond star ratings, risk scores to reveal the strategies, innovations, and mindsets driving real-world healthcare excellence. In this episode, we're going to deliver clear insights, bold frameworks, practical ideas for healthcare executives, operators, clinicians, innovators to make sure they are ready to get to the next level. They're improving quality, scaling value-based care, or reimagining patient, member, or population outcomes. Here we are. Today, I have one of the stars in healthcare, Charles Baker, healthcare leader with experience in operations, process improvement, finance, clinical social work services. He's been actually really responsible for agency-wide initiatives in hospital and ambulatory settings, generating really high-level results, clinical quality, compliance, financial performance. And Charles is also one of my colleagues at ATTAC Consulting Group, a good friend and a great guy. Charles, welcome.
Yeah, thanks, Subbu. Thanks for having me.
Great, Charles. One of the reasons you were chosen as one of the stars of the podcast, and you're my first guest in this podcast because you are very unique in a way in healthcare and your unique professional experience. We'll talk about that in our conversation. But I want to first, introduce you to my audience. Tell me about you, not only your professional experience, about you, Chuck Baker, as a person.
Yeah.
And would love to hear more.
Yeah. Well, thanks, Subbu. Charles Baker, as you mentioned, I'm Vice President of Compliance Solutions at a consulting group primarily focused on government-regulated markets, Medicare, Medicaid, ACA, qualified health plans. So the real fun stuff, right? That's always static, never changing, and we always have firm direction from the federal government on what to do next, right? My journey into the government-regulated health space has been quite a unique journey. From where I started out. I started out my career as a clinical social worker working on inpatient psych units at the University of Minnesota. And during that time, we would have roughly 10,000 patient visits a year to our psych units, and I always thought to myself, did we really have 10,000 unique patients, or was it the same 1,000 patients that came to the hospital just on different days, right? And so I really started to sit with that and think about healthcare holistically and how the hospital system interfaces with the community at large for more than just medical care, but also a lot of, the buzzwords of today, the social determinants of health, right? Because a lot of the times what you saw was, especially on mental health inpatient units, a lot of the times those patients really didn't need to be there for medical care so much as they had social determinants of health that were impacting their ability to function well with community. And so at that time, I decided, I wanted to have a big change within the environment and really make a difference in the community at large. And so I sought to get a second master's in healthcare administration. I can distinctly remember on my first day of class in my MHA program, one of the COOs or chief operating officers from Optum Healthcare was standing in front of us. And at that time, I was a bright-eyed social worker who had the best of intentions, and Optum Healthcare was standing in front of me. And the first question asked was, how much profit do you think that insurance companies make on an annual basis? And for me, the social worker, hundreds of billions of dollars, right? Down with the insurance companies. It's Medicare for all, right? And so I always reflect back on that from where I started to where I am today, and kind of how that has shaped my perspective. And now I'm in that environment, right? And I see through what I've done the impact that these government regulated healthcare insurance products can have on the community at whole, right? I have seen how, when done really well, STARS initiatives, quality of care initiatives, risk adjustment initiatives can have a beneficial impact on the communities that we serve if they're done right. Right. And so that's kind of where I've come from and where I've gotten today. I've sprinkled in some leadership in the hospital space there as well, but here I am today.
That's awesome. And exactly as you said, I think clearly that experience and that journey shaped you, right? That Optum example is an interesting one. right? Everybody who comes in the health plan, because I started my journey in tech and financial services, the first thing you jump in and you're in a health plan, you just learn a lot of different unique things. And you being a compliance officer, in a large health plan in Michigan, and that is a completely unique direction. Tell me about your experience a little bit more, and clearly, like how some of the journey that you went through previously when you came into the compliance role, and the work that you do now. So one of the national thought leaders, through ATTAC Consulting Group, like how that shaped you, how is it helping you in your current work that you do?
Yeah, I mean, I think all too often it's easy to vilify the insurance company, right? The headlines, the news that we see on a daily basis, the profit reports, the things that are happening on the congressional forefront, and how we are talking about insurance products. But really, when I got into it, there is no better a resource than the health insurance company to be able to drive community healthcare, right? To be able to drive population health initiatives. And so being in that compliance seat was a really eye-opening experience for me, because you knew that what you did had an impact on a vulnerable person's life, right? Like the initiatives that your organization, the supplemental benefits that you were going to offer, the care management techniques that you were going to do, prior authorization that you were going to apply to certain services and products. You knew that was going to have an impact on a person's life. Mary, Bob, Joe, your aunt, your uncle, your cousin, right? Like it has an impact. And so I really tried to marry those two worlds together. My social work world and kind of this idea that, the insurance company is a necessity, and they can be in the driver's seat when it comes to population health. One of the things I didn't mention is I used to teach population health for a university here in Michigan. A lot of the times when you see those population health initiatives on a broader scale, you see them being done by insurance companies, and I think you saw that with that. And I really tried to blend those two together, right? And the framework that I always worked on under was really about governance first, but agile always, right? Because you always want to be able to respond to the next big thing. You always want to be able to respond to regulatory requirements. You want to be able to respond to your product team when they're trying to implement these new and innovative benefits that may not fit into a nice, pretty compliance box, right? But like, how do we do this together? And that's really the way that I always talked about compliance within my organization, was approaching it as a consultant. It is not my job to sit there and say no, right? Sometimes there's black, sometimes there's white, right? Sometimes there's hard no's, hard yeses, but there's that gray area. And so how do we work within that gray area, for one, for the good of the business, but two, for the good of the member? And a lot of the times, and my primary experience has been in not-for-profit healthcare provider-owned healthcare systems. And so a lot of the times what we were doing, the business needs were to kind of augment the entire system, right, for those profit margins. Yeah. So that's really kind of how I approached it from my compliance seat.
Yeah. That's awesome, Charles. And that's one of the reasons I also love working in engagements with you from bringing in the population health lens, right? Because there's so many kind of like nuanced functions, within the ecosystem of healthcare. You got compliance, you got STAR, that itself is a whole, different kind of unique, perspective, quality, you got risk adjustment, you got cost of care. And whenever we talk about, not only with our clients, but the approach that we take is bringing the whole population health management approach. And with that approach in mind, there is a lot of things going on in managed care right now. Right. Every year there's lots of things going on, but at the same time, with a lot of the new regs, and you've been in other podcasts, and I've been called to other podcasts, and we get calls from customers and in the industry, you speak at conferences, we get a lot of questions, right? With new bills coming in, new guidelines already proposed by the new administration. So as a former compliance officer of a health plan, having been also on the provider side at the same time in the past, what approaches will you undertake to lead in this tough environment? You talked about the approaches of population health management, but what would you do broadly right now if you're a leader in these organizations?
Yeah, I mean, this is a really team sport, right? I think traditionally a lot of organizations are very siloed, and it's difficult to break out of our silos. So I sit in my compliance or my regulatory affairs silo, and at times we as a profession in the compliance space can think that we sit on high and roll out things to those down below and say, hey, that's not my problem, you figure it out, right? But I think that's a really antiquated approach. I think, and what I advise health plans and what I help health plans to do is to really ingest all of those regulatory requirements and then figure out how we can operationalize them from a business perspective, an operations perspective. What do we need to change in our appeals and grievances? What do we need to change in our claims processing? What do we need to change in utilization management? Like the real blocking and tackling type stuff. But then let's get strategic about it, right? Let's have some regulatory work groups, some meetings so that we get out of our silos and have discussions, right? When we look at the new regulation and proposal to collect utilization management data for Medicare Advantage organizations, that's just not a government requirement that is going to be coming down the pipe, right? It's in the proposal stages. They're asking for comments right now. That's not just a regulatory requirement, but what a really good opportunity for you to take that memo and be proactive and start looking at your data today, right? Like how can we look at our utilization management data that we're going to have to be submitting through HPMS in the very near future anyways? This is the way that CMS is going. You can tell through program audits and the RADV stuff that's going on that this submission is not going to go anywhere. But how do we right now, before it is a government requirement, a regulatory requirement, how do we look at that data now and glean some information for us as an organization? So I'll give you a for example, right? So when we're talking to health plans and coaching health plans around utilization management and prior authorization data, you should be tracking and trending the information of when you are having those initial denials, and then what does it look like on the appeal process as well. And so you really should be tracking and trending that information. And it was just announced today that from AHIP, I believe it was 48 of their members are reducing their prior authorization requirements by something ridiculous like 65%, right? So large health plans, Elevance, United Health Group, the big players that are all part of AHIP, because they went through and they looked at, well, we can deny this on the initial org determination, but a lot of the times upon appeal, we're overturning ourselves. Or is it really cost effective to be applying the prior authorization requirement on these things specifically? And so you too, as an organization, can go through this exercise as well by looking at the data that you're going to have to produce either through a CMS program audit universe or through HPMS data submission. Look at that information and start making some decisions around applying prior authorization requirements.
Yeah. No, that's such a cool and timely example, right? And just a lot of the things around prior authorizations are ready to get explored, because it is impacting member experience. It is impacting the health plan operations. Clearly, it's putting a lot of demand on providers. At the same time, I love that you kind of work on connecting the dots here on not only, I love what you talked about, not only it's the governance, but it's also really agility in action, right? That's where I think you're advising your teams, advising and working with organizations. But if somebody is in the health plan or at a provider group, right, they don't have enough staff, things are coming down the pike with all these regulations, and they don't have that expertise or hands to kind of work on this. So talk us a little bit more, especially within your group, right, ATTAC Consulting Group, within compliance function and the work that you do, how you help. You gave a clear example on the utilization management, but how do you help some of these organizations? What are you seeing right now with health plans who doesn't have that expertise, and how do you kind of come in and really go alongside what in the frameworks that you talked about?
Yeah, I mean, it's really a maturity methodology, right? So there's level of maturity within organizations, and there's maturity within discrete departments, right? And so you could have a very mature and sophisticated product development team. You could have a very mature and developed care management team, but you're really kind of struggling within that governance and regulatory oversight space. And then we'll help plans kind of identify where some of those gaps are, and then come up with a roadmap on how we will mature, build out the program, or provide augmentation services alongside them, right? So one of the most popular things that we do right now is we do a regulatory review and an insight digest. And so every Monday morning, we take all of the HPMS memos from the week before. We create a summary of them. We say, hey, operations leader, hey, claims leader, hey, appeals and grievance leader, this is applicable to you, and here's what you need to do about it, right? So we start to break out some of that. Paying me to do that long term is probably not a viable business solution. And so we help you by giving you the framework so that you as a health plan can start to build out some of that as well. I mean, it is a regulatory requirement that you as a compliance team are reviewing that information and disseminating it as necessary to your operational areas. But it's the level of detail and expertise to be able to read the nuanceness of them, pick out who is the appropriate business owner and what do they need to update, right? Like from a compliance perspective, if I get an HPMS memo that's talking about my updated marks enrollment data, and I need to look at my TRRs or DTRRs or MRRs or these sorts of things, I get a little foggy in the face and I stop paying attention very quickly. But I learned quick enough that those were the acronyms for our enrollment files to make sure that we have a concurrent enrollment review process, right? And so we help organizations go through that maturity process to be able to do that level of regulatory breakdown. There's a cadence to CMS, right? There's a cadence on when they put out information, when they put out draft rules, when they put out final rules, when the comment period, it's all regulatory required on what that cadence looks like. So for some of the bigger pieces, we do a summary, right? We do a summary that comes from a compliance and regulatory perspective. What breaks it down into you as a health plan should be doing that as well, right? So whether or not that comes from a consultant, whether or not that comes from a professional organization like ACHB or AHIP or any of the other organizations that you're a part of, those organizations are producing that information as well. So make sure you're reviewing that. Not everybody is as weird as I am and will sit down and read a 792-page document when they're on a Disney cruise in the middle of the Bahamas.
Yeah.
I did, but others do not, right? And so think about where you're going to be getting that information.
That's awesome. Devil's in the details. You got people have to, read it. Like, it's interesting. Like, in the organizations I've been part of, like in my team, like I would ask the team to read the spec. Like people come with us like, hey, what is here? It's literally available. Click of a button. You can just go through the spec, understand it, and devil is in the details here. And you can always not bring the water to the horse. You have to really make sure like the horse drinks the water in a way. So I think the HPMS, not in the HPMS memo, like contextualizing it and then also understanding it, not just passing on the buck here. I think that's exactly, I think, what you're kind of talking about in all the solutions. And I've seen that in action, all right? You and I kind of collaborate a lot within the work, not only because the example you talked about impacts, there's the cost of care component, there's the compliance component, it impacts STAR clearly, depending on the member's journey in healthcare, not only from a CAPS perspective, but also in the clinical care measures, would clearly impact risk adjustment because you need to kind of really document the condition, etc. So I think I love the kind of the connectivity part. It's a whole theme here that we're talking about. So shifting the focus a little bit, I think we're talking a little bit on Medicare Advantage with the HPMS memos here, right? Shifting the focus on Medicare enrollees, Medicare Advantage. There's obviously the STARS pressure for health plans and providers. There's cost of care pressure, and we have risk adjustment on RADV. Let's talk about RADV here, right? I'll put the things in context for the audience, and I've talked about it in the first episode here about the importance of making sure risk adjustment is not looked at revenue generating. It is risk accuracy. It's a population health program at its core. While it has the models has its deficiencies and there are opportunities to improve, it is a population health management opportunity for sure, for health plan and providers. So Charles, you put an awesome LinkedIn post the other day, right? About what's going on this is just not a noise. The RADV notice came out. And for example, today is June 23rd. We're, recording this conversation. Today, there's also repeated memos from CMS reminding plans to send their deletes. What you quoted Dr. Oz here, right? Tackling MA upcoding is relatively enjoyable because we have bipartisan support. So I'm just quoting some of your posts here because it was very poignant and very kind of timely. So what are your thoughts here, right, as a compliance officer? And then I think we can talk a little bit in the context of population health, your approaches, etc. But from a compliance and a pop health leader standpoint, with RADV, what are your thoughts on plans, but not only plans, but providers, the whole ecosystem, what needs to be done from your perspective?
Let's take a journey back in time, right? Let's take a journey back in time when we first started talking about HMOs, controlling cost of care, and appropriately identifying how much it costs to take care of risk adjustment, value-based care, value-based contracts. All of these things were supposed to be able to get us above that hump to provide quality care to the members that need it, right? The risk score calculations, the value-based contracts that insurance providers have with providers was to increase the quality of care that members provided, right? At some point along that way, risk adjustment moved away from being a quality-based initiative to be able to identify the sickest members within your population so that they get the care management services, they get the supplemental benefits, they get the additional care, and we're going to pay you to give them that care because we're identifying that they're the sickest people out there. We somehow moved away from that to now this is a revenue generating initiative, but we're not going to do anything with that information. And I think that's always been the hardest thing for me, right? In-home health assessments, they're great. You get people to go in their home, you identify their chronic conditions, you identify the things that these members need, things that a overburdened primary care physician may not be able to get. Your doc down the street, Dr. Bob on the corner that I've been seeing for 30 years may not be capturing all of these things or even know how to deal with it. But now we get in-home services that are appropriately identifying the social determinants of health and the chronic care needs that member have for the purposes of risk adjustment. Now, when we're doing that for the purposes of risk adjustment, is it A, for the betterment of the quality of care that the member is going to receive, or is it B, that I, as the insurance company, get more money out of that, right? It is supposed to be for improving the quality of care that the member receives, that there is a feedback loop that occurs between the health plan and the provider group to say, hey, we did a in-home health assessment for Subbu. It turns out that he has diabetes, food insecurity, can't get his insulin, he can't get his testing strips, and that's why his A1C is 8.2, right? That information should then go from the insurance company to someone to do something about. So let's design initiatives around that information, right? So I, as the health insurance company, am now going to get an inflated risk score because of it. And I'm going to put down their HCC that they have, that they have diabetes and all these other things, that I'm going to go ahead and get a revenue uplift for that. But then I should be investing the money into it as well, right? And so if I have these value-based contracts with the provider groups, and it should be on the provider to, one, understand that I have an A1C of 8.2, right? That I have food insecurity, that I can't afford to get my insulin and I can't afford to get my test strips. What are we going to do as a system about that? And so the fact that CMS has awoken to this idea that this is what it's being used for. We as a compliance organization, we as an industry, we as good people that got into this field for altruistic reasons need to double down on that. We need to say, okay, this is our time to set our true north. And our true north is for the betterment of our members. Now, I'm not indicting all risk adjustment people or value-based care people, right? We all have altruistic means, and we have our marching orders, and there's a lot of good people out there doing really good work. That's not what I'm saying. But what I am saying is that somewhere along the line, we lost that true north. And that information just became another piece of information within a larger scope of information that we don't do anything about. And so I firmly believe in what CMS is doing. Audit 1,000 charts. Why 200? Let's do 1,000. I mean, if we're really going to do this, then let's do it all out. And I hope, in what I have seen through the delete process, through everything, is that plans are now flipping on their head and taking a more population-based health approach. And so now, not only do I have these gap closure initiatives that tie in between risk adjustment, stars, quality, HEDIS, all of those things, it's all starting to fit together, right? So if we take that quality and the member as our true north perspective, especially within a risk adjustment world, then I think the industry is going to be better for it. There is bipartisan support across the industry to hold health plans accountable to do the right thing. If the health plan isn't going to do the right thing on their own, then the government's going to step in and tell you to do the right thing, because the Medicare Trust Fund is running dry. And
totally. So many gems in what you said there, right? I mean, even like the simple opportunity, I say it's simple opportunity, the in-home assessments. Data from in-home assessment needs to just go to the provider, just not a letter that's going to get trashed. It needs to go into the provider's hands so that they can follow up on that simple A1C example, right? So it's very actionable. Speaking of actionable and, auditing, right? Right now, obviously, we are in the inflection point, right? With lots of RADV audits going on. As part of ATTAC Consulting Group, we are right now, not only the approaches that we are talking about here, Charles, that you talked about, that I've been talking about, we are supporting organizations to mitigate RADV in the future, look at quality angle, the operations angle, the compliance angle. You talked about everything's a team sport, and kind of really hand-holding some of these, health plans and providers in this era. And which is something that I'm really excited about, right? Because I came and been in healthcare for all, from an altruistic perspective as well, right? You connect to the members' care and, from a quality, perspective, reduce costs and put a really awesome supplemental plan for members, who can, take advantage of it. So we are right now, for folks who are listening, if you need support currently for RADV, ATTAC Consulting Group, we've been supporting RADV from the HHS side for a number of years. Since inception, we've been supporting Medicare plans right now who were picked for RADV. So reach out to Charles or I if you need support. So, but at the same time, there's a support right now and what needs to be built in the future. And Charles, we are in the middle of the year, literally, right? So July almost right now, and many of the health plans and providers are thinking about finishing the year strong, right? From whether it's closing the gaps in care, whether it's stars on the Medicare Advantage side, quality on the Medicaid side, or ACA or commercial, planning the following year, preparing for AEP right now. So my question is twofold. One is, what do you recommend at this juncture for health plan leaders and operators? And then after that, what do you recommend for a large health system or small mom and pop provider, what they should be focusing right now to make sure they're compliant with all the things going on, but also improve the health of the population that they're taking service for?
Yeah. What do you know about your health plan? Ask yourself that question. Do you feel confident that if CMS was to walk in today, they audit 200 charts, what are they going to find? Do you know what they're going to find? And if you don't know what they're going to find, you as an executive, a CEO, CFO, need to have a firm understanding of what CMS is looking for and what they're going to find. If I were in a health plan right now, I would be doing a lot of chart audits. I would be doing mock RADVs. I would be looking at targeted screening. I would be looking at the OIG high risk coding list, and I would be targeting those charts. I would be looking at what CMS has put out in terms of how they're going to extrapolate and target cases through the RADV process, right? Make sure that you are aware. The delete window is still open. What is today, the 23rd?
It is for a few other years. Today is done for one payment year.
Right. So 2019 is out. But you still got a lot of other payment years in there, and they're going to get caught up. Now, how are they going to get caught up? I don't know. Maybe they did find those 2,000 coders somewhere. They are going to get caught up. This is coming. It is going to happen. And so you as a health plan leader need to act really quickly and start getting some audits, start getting some chart reviews done. Providers, wink, wink, nod, nod. This is going to fall on your shoulders too. Because guess what the health plans use for their HCC capture? Your documentation. They're going to be looking at your records. And so you really need to be looking at your clinical documentation and your EMRs to make sure that your EMR and your documentation will stand up in the face of an audit. Now, it isn't as prevalent as I thought it would have been by now. But one of the things that I preached when I was a compliance officer was to really look at our provider contracts between the health plan and the provider group and have clawback provisions for when a medical group's documentation doesn't stand up in the face of the audit that they're on the hook, right? And so look at your value-based contract agreements and understand, am I on the hook if this documentation doesn't stand up in the face of an audit, right? And so it's kind of one. Two, have an enterprise-wide ownership. Right? This is a team sport. There is people from compliance, finance, risk adjustment, IT, population health, really have enterprise ownership of these initiatives. CMS is telling you loud and clear what they want you to do. Listen to them and stand up these processes and start breaking down those silos and have cross-functional teams and enterprise ownership with all of these initiatives. Step 3. Look at all of your policies and procedures in the way that you talk about your risk adjustment program. So whether or not it's the CMS RADV that everybody is going to get picked for, or you are the lucky recipient of an OIG audit, look at your policies and procedures, because if it hits the fan, they're going to look at your policies and procedures and the way that you as an organization describe your risk adjustment program. And if you as an organization are describing your risk adjustment program as something other than a population health initiative, you need to be making updates to your policies and procedures now to change the verbiage around your risk adjustment program.
Yeah.
From like a STARS perspective, AEP perspective, I will quote my good friend Caleb. This is all Caleb's. He's a friend from another health plan. His big thing is to bring back patient journey maps. Please, dearest health plans, bring back patient journey maps, right? Sit down and look at all of the interactions that a member is going to have and all of the important interactions that a member is going to have with your health plan throughout the year. Their ID card, their office visit, every time they call you, every time they have a grievance, and start mapping out that process, that journey of the patient. Because guess what? CAP scores now represent a large portion of your STARS measures. And guess what? Republicans and conservatives in Congress love transparency and love CAPs.
Absolutely. Charles, music to my ears. You broke it down really well, right? I think the intersection point you all talked about, I had the luxury for a number of years having quality stars and risk adjustment all under my domain. So it was a relatively easy task to kind of bring all the pieces together. Obviously, you got the portion that we need to integrate it and all that stuff. But we talk about it in the industry a lot. Yeah, it needs to be together. It needs to be, well, let's make it happen. Right? Let's make it happen, right? The time, as you're stating, is, well, the time is now, right? Time is now. And one of the things I would add to what you mentioned is also budgeting, right? I highly encourage people not to wait for budget cycles to start. Start now. Start now before it's too late. Put your asks out there. And Charles, you beautifully explained the step-by-step process, both from a provider perspective and a health plan perspective, right? And especially the policy and procedure part. It sounds painful for certain, could be painful for certain people, to be honest with you. Some people thrive in the policy and procedure arena, some people don't. But it's such important documentation, the way you actually present your incentive program, the way you present your actual program. And this is a fantastic opportunity for the next few months to kind of polish it, put it out. But if you guys need help, obviously, Charles is here, I'm here, and the rest of the team at ATTAC, is here. But I'm sure we will be talking more in a future episode, Charles, a little bit, further. But I loved your 3-step approach that you talked about. Focusing a little bit on the wrap up, and this has been a fantastic conversation, Charles. It's just time just goes really fast in this, right? I feel like we've just touched at the tip of the iceberg here. So just a few parting thoughts from you, right? There are so many consultants and advisors out there, right? Obviously, from the conversation here, you've lived through many of this, both on the health plan side and the provider side, and you bring a unique perspective with, the approaches that you have. But there's so many out there. But what is unique about your approach from the ATTAC side? And I think I talked about it in my previous episode on how all of these bringing together helps. So just a parting thought on the unique perspective that you bring, compared to other consultants and advisors and thought leaders out there.
Yeah. So I talked a lot about teamwork, breaking down those silos. You got to practice what you preach, right? And that's what we really try to do within our organization. So it's not just about compliance. It's not just about operations. It's not just about quality or risk adjustment. It's all of those things and how they work together. So I partner with folks like yourself, Subbu, and other folks within our risk adjustment and data analytics team, so that we come up with a comprehensive view of your organization holistically. Looking at the data, we're making data-driven decisions, and we're coming at this with our industry expertise from folks that have been there. Right? We don't have any junior staff within our organization. All of our subject matter experts are former chiefs. We're vice presidents, we're directors and above, right? We don't have any junior intern staffs that we're just going to pass you off with. You're actually getting work from people that have been in the trenches for a number of years. And I think that's really what helps us stand out amongst the big folks, right? We're also a smaller boutique firm, right? So we have a lot of agility and nimbleness to go in the direction that you want to go. Sometimes organizations will say, Charles, what do you think? Sometimes it's not about what Charles thinks, it's about what you as an organization are trying to accomplish, right? What are your goals and objective? And I can produce a roadmap to get you there. But this is a two-way street. So we really try to take the time to listen more than we speak, and provide guidance when all of you.
Awesome. Charles, where can people follow you? I know you are also active on LinkedIn. What upcoming conferences that you're going to where people can meet you?
So I am out on LinkedIn. I post things quite frequently, and I try to be pretty funny about it. So if you want a good bit of humor, come and follow me, Charles Baker, MHA, over on LinkedIn. Coming up, I'm going to be at the Michigan Association of Health Plans Conference in Traverse City. I fully plan on winning their golf outing this year. If you want to come and finish second in the golf outing, you should go to the Michigan Association of Health Plans Conference. And then later this year, we're going to be at the Health Industry Collaborative out in California, the California Association of Health Plans. So, yeah, just really looking forward to meeting.
Awesome. Charles, thank you for joining me today. I appreciate it.
Thank you for having me, Subbu.